and symptoms are more important than numbers. You know, numbers give a guide, and your folate was clearly low. So in people who have symptoms, we want their folate to be above 10 and even 15 to 20. And that's the difference. If you have a folate of 5.38 and you're well, that's fine. But if you have a folate of 5.38 and you have symptoms like you did, then you're not fine. It's the same with B12. You know, the real best B12 we'd like is 400, 500, 600, something like that. And if somebody is well and has a B12 of, let's say, 250, then that's fine. But if they have symptoms and their B12 is less than 300, then I would treat it. And that's the key. It depends on the patient and not just the blood test. The patient is always more important, and the blood tests are not perfect. So if you have Marmite on your toast, or you have breakfast cereal, which is supplemented with B vitamins, which many brands of breakfast cereal are, or if you drink oat milk or soya milk, and most of the brands are supplemented with lots of vitamin B, or you have multivitamins that have vitamin B in it, all these things will make your B12 and folate test look normal, but they're not, because the supplements interfere with the test and make it look normal. And that's the problem. The tests are imperfect. And with iron, it's the same. People develop symptoms if their iron levels, their ferritin is less than 50, and the symptoms can get quite bad if the levels are less than 30, and if the ferritin is less than 10, then the levels are really bad. So it's about patient symptoms and levels, and it depends on which test, and they're all interfered with, so none of the tests is perfect. I wish we had a test that would say definitively, yes, your B12 is low and you need treatment, but we don't. We have to go by patients, and sometimes we have to try these things even if we're not 100% sure. So we might say, well, the level is okay, a bit low, but you have symptoms, so we're going to try it. And that's the key, really, looking at the patient, their symptoms, and the blood tests.
That's brilliant. Thank you. That's really helpful. So here's another question I think is really pertinent. A lot of people from the UK are very concerned with this one. How can we persuade the NHS to review the ways they diagnose and treat B12 deficiency?
Well, it's really hard, and it's all about education and knowledge, really. And we have a lot of new knowledge that we didn't know 20 years ago when many doctors trained. So I trained 30 years ago, and we knew nothing really about B12 then. Although we gave B12 injections, we didn't understand the condition. We didn't understand how to treat it. And we know a lot more now based on new research and new findings from trials. But the problem is everybody has to catch up. So really, it's about educating GPs, educating other doctors, and patient help groups like the Pernicious Anemia Society and the B12 Society are fantastic like that. In the B12 Society, and myself and some other doctors, we're lobbying Parliament. We're going to the House of Commons to lobby Parliament because one of the MPs, who's a minister in the government, she has B12 deficiency. So we're going to meet her and other members of Parliament. So it's about changing hearts and minds and educating people. Nothing happens quickly. Medicine, people's views are entrenched. In life, people's views are entrenched, you know. But in medicine especially, doctors are stubborn, and we take a long time to learn. So these things will change, but they'll change slowly, and it's frustrating in the meantime.
And I actually want to add here, so the Club B12 that's focusing on this is actually the charity that I'm going to donate all the money that we receive from this event. So thank you so much to everybody who signed up, because you're contributing to helping that charity make this happen.
Yeah, so Club B12 is a group of 200 healthcare professionals. So that's doctors, nurses, biochemists, geneticists, scientists, and patients who've recovered from pernicious anemia, patient help groups, patient support groups. And we all meet every 2 weeks on Zoom, and then once or twice a year in person. So our next meeting is in Rotterdam in June. And we look at all the research, we plan new research, we talk about how to improve patient care, and we benchmark our care based on other doctors around the world, so other clinics. And from that, we learn from other people, both from doctors and patients and scientists, and try and advance the care. But there's only a few people in the UK on this group. There's a few from all other countries in the world. So this is a group of really interested professionals and patients who are really looking at this. And I'm one of it. And that's the charity, basically. We're looking to raise money to improve treatment and care based on other people's experiences around the world, and to try and improve education and help, you know, for example, the B12 Society hosts teaching events for GPs to try and teach them about it. So these are the things that we're trying to do, education and research.
Okay, so coming back to some of the questions, thank you, Andrew. Cool. Coming back to some of the questions that patients have, that are very directly linked to their treatment. How much B9, i.e. folate, does one need to take when you take B12? Is there a recommended ratio?
So the answer is a lot. And there's lots of different views. Like anything in life, there's lots of different views about how to deal with things. So my own opinion is whenever you get a B12 injection, you need extra folic acid. So 5 milligrams with every injection. So that could be 5 milligrams every other day if you're injecting every other day, or 5 milligrams once a week. And the answer is you've got to test. You've got to keep your folate level 15 to 20. So there's no point having a massively high level, but a much higher level than normal to get, and it's involved in the metabolism of B12. So you need high folic acid levels to get B12 to work. So the blood test for folic acid is useful for doing, but the blood test for B12, as soon as you start injections, is absolutely useless, Adelina. It just shows more than 2,000. And many people say, oh, you need to stop your injections because your blood test is more than 2,000. That's not true. You need B12 until your symptoms are better. So we can test for folic acid, but we can't test for B12 once we started injections. And that's the problem. And it's understanding the knowledge of that. And it's to do with the way the blood tests work and what they measure. But basically, you need lots of folic acid, at least 5 milligrams with every injection.
That's a really good point. So just a quick note. Andrew, I'm not sure you know this, but I actually bought from Germany some folate because orally it wasn't really doing much for me. So I actually inject folate 5 milligrams, exactly like you say, with B12 in the same syringe, and that's how I do it these days. I don't just inject the B12 anymore. I have obviously the B12 on the NHS prescription, but I also actually bought folic acid as an ampule.
Yes, and of course there's also patches, Adelina. So a woman who has pernicious anemia, who is a member of the B12 Society, she invented B12 and folic acid patches. So this can be an option for you once you're settled on injections, and you could get your folic acid by patch and your B12 by patch instead of by injection. It doesn't suit everybody. It doesn't suit people who've got autoimmune antibodies. But in some people where the stomach is the problem, you could bypass the stomach, go a different way by giving the patches. So this is something that we're researching, but I've tried it with quite a few of my patients who've had very good results. So, it's interesting. Patch technology, nicotine patches, hyacinth patches for sickness on a boat, fentanyl patches for painkillers. Patch technology is a very interesting way now of delivering drugs.
We have a couple of questions, and I will go through both of them. Oh, gosh, we have more questions now. I'm just going to go through this one at the moment. So what about methylated B9 quantity instead of folic acid? What do you think of that? Do you have any?
Yeah, so that's a very good question. Some people can't absorb B9 folic acid on its own, and they need it in the methylated form where it's sort of pre-absorbed or pre-methylated. And they can then use it, and then they need 400 micrograms of methyl folate every day instead of a bigger dose of the folic acid every other day or whatever. That works for some people. Maybe it's about 10% of people. And like anything, if you've tried folic acid and it hasn't worked or it's upset your stomach, then you could try the methylated or methyl folate, or folinic acid is another name for methyl folate.
Right. So, very good question from Becky White. What can a patient do when a doctor does not heed the guidelines, research, etc., regarding B12?
Try or find another doctor. I mean, the answer is if doctors are entrenched in their views and you disagree with them based on what you've read or what you understand from other people, is you find another doctor is the honest answer. You can't really do anything, because if a doctor doesn't believe in it and doesn't want to do it, you just have to find another doctor, Becky, I'm afraid. Someone who speaks your language and can understand it.
Emma Schremer says, is there a connection between low stomach acid and B12 deficiency? I am searching for a reason for my B12 deficiency, not vegan.
Absolutely, Emma. Low and high acid. So 50% of patients who have B12 deficiency, the problem is primarily in their stomach. So they do not absorb the B12 from their diet. Now, obviously, a vegan diet has no B12 in it. There's only B12 in animal products, I'm afraid. But even vegans can be absolutely fine if they supplement, but some of them cannot absorb the active, the real form of the B12 that you need. And you either have too much acid or too little acid, or you've had some of your stomach cut out, you've had surgery to staple it or remove some of your stomach, or you have Crohn's, or you have ulcerative colitis, or you have celiac, or you have autoimmune disease. All these things affect the stomach. So B12 deficiency is a problem with the stomach that doesn't allow you to absorb the B12. And one of the reasons is low acid or PPIs like omeprazole or lansoprazole that suppress the acid for a long period of time. And if your acid is abnormal, you cannot absorb B12, folic acid, vitamin D, and iron. So the thing, Emma, that is very important is it's not just B12. It's also the iron, the folic acid, the vitamin D. And we've got to look at all of it.
My stomach acid was affected by metformin. So that's another drug. And I've heard some people's stomach acid being affected by the contraceptive pill. So, yeah, there's a lot of... Okay, brilliant questions coming up. Should you always inject B12 after a gastric bypass? I have actually some experience with that, but I'll let you speak first.
Well, the answer is yes, because you haven't got a stomach, because it's been bypassed, so you won't absorb B12 because it's only absorbed in the stomach. So you could eat as whatever you like and take whatever supplements you like, but you will not absorb the active B12. You do not produce intrinsic factor, so you will need B12 injections. So the simple answer is yes.
Folks, just to warn you, by the way, this is a recorded call, and I plan to put it on YouTube so other people can get access to this information as well. So if you don't want your name to be there, please don't kind of type up questions, because I'd like to share this video publicly so others can get access to the information. Please do message me afterwards if you have any concerns about this. A question from Emma Schremer again. Does thyroid disease cause low stomach acid?
No, not really, but many thyroid diseases are due to autoimmune conditions, and the autoantibodies that you have don't only attack your thyroid, they attack your whole body. It'd be really easy if they just attacked your thyroid, but they also attack your stomach and stop the production of intrinsic factor and stop you absorbing B12. So the link is due to the autoimmune disease, and it also affects your iron, and when your iron levels goes off, it affects your thyroxine and your thyroid function. So there's a big link between thyroid disease and iron, and thyroid disease and B12 and vitamin D. So as ever, you've always got to keep an eye on all these things. So thyroid disease is not just thyroxine, it's also keeping an eye on the other things.
Fantastic. Thank you, Andrew. Here's the case study we have. I'd really love for you to comment on it. I think I already have some opinions of what I'd say about this. A 45-year-old person starts supplementing when B12 level is 350. Person had tingling on one side of the face and arm. Is it concerning if after taking 1,000 micrograms of sublingual B12 every day for 30 days, the level is at 700? Should it be much higher than that if supplementing? What's the best way to test?
That depends on the answer of what the level was before you started supplementing. So certainly tingling and numbness on the side of the face is a new...
That's
350. Okay, yes, sorry. So tingling and numbness on the side of the face is a neurological symptom. It could be due to the B12, but it could be many other things. And 350 is a particularly low. I would treat it if it's less than 300, but it might be the B12. And as I said, the blood test is a bit rubbish, can be interfered with anything from Marmite to breakfast cereal to multivitamins. So maybe 350 was really 250. But oral supplementation doesn't really work if you have neurological symptoms. You only absorb the inactive form. So the oral supplementation makes the blood test look wonderful. 700, wonderful. Everything is fine, go away. No, you're only absorbing the inactive part from the supplements if you have a problem, and you need injections rather than oral supplements if you really have neurological symptoms. So oral supplements do not work in that situation if you have neurological symptoms. They only work to stop you getting B12 deficiency. They do not treat B12 deficiency. So if you have low B12 levels and you have neurological symptoms like tingling or pins and needles or numbness or brain fog or forgetfulness or any of those neurological symptoms, then you need to treat it properly with injections. Oral B12 will raise your levels, but it will not correct B12 deficiency. It's good for preventing it, but not for correcting it. And that's the fundamental difference.
Nailed it. Yeah, beautiful. Okay, another question from Julie Soden. Can the damage caused by PPIs be reversed with B12?
No, because the damage caused by PPIs that cause the B12 deficiency. The damage caused by PPIs can be reversed by stopping the PPIs and healing your stomach. So a lot of this comes down to healing your stomach. So nutritionists are good at healing stomachs. So things like foods, when you eat it, what you eat it, how you eat it, with avoiding foods that don't agree with you, that upset your stomach, that cause inflammation, and all those sort of things can heal your stomach, and stopping the PPIs. But the effect of the PPIs is the low B12. Does that make sense? It's about cause and effect here.
Feel free to type a response, Julie, if you're still confused. Why does nitric oxide not affect non-B12 deficient patients the same as B12 deficient patients? Is it the low level of B12 in the body that causes the increase in fatigue, loss of function, and other symptoms?
Yes, but nitrous oxide, not nitric oxide. So nitric oxide, Anne, and hello, Anne, lovely to hear from you. I know you because you're one of my patients, if it's the same Anne that I know. And nitrous oxide stops the B12 metabolism and stops it for months. So people who have nitrous oxide with their general anesthetic, or nitrous oxide is also called entonox, and you have it in labor to control pain in labor, or you have it sometimes if you have a fracture, you break your leg and they give it to you to set your leg, or in the back of an ambulance. Fantastic painkiller, destroys B12 metabolism for months. So if your nitrous oxide levels are low, when you have your nitrous oxide, it just sends you right over the edge. So, and if your levels were okay, you can cope with a bit of nitrous oxide. If your levels were already low, you can't cope, and it sends you over the edge into horrible symptoms. And so really, we're focusing on this. And in the end, I think nitrous oxide is going to disappear in 10 years' time. It's a drug of abuse. People use it in metal cylinders at parties to get high. And then if they take lots of it at parties to get high, they end up with subacute combined degeneration of the cord. I understand that last week, 12 people, young, well people, presented to St. Thomas's A&E with horrible neurological symptoms from abusing nitrous oxide. So we have this epidemic of abuse of nitrous oxide causing horrible neurological symptoms due to acute B12 deficiency. So nitrous oxide is a great drug for analgesia, but has terrible side effects that we're only starting to learn about it. So people who already have B12 problems, nitrous oxide, bad.
So does everyone with B12 deficiency have pernicious anemia?
Well, different people argue. This is about a name. B12 deficiency, in my opinion, is pernicious anemia. It's the same thing under a different name. Some people say that pernicious anemia can only be caused by autoimmune disease. But I say everyone who has B12 deficiency has pernicious anemia. It's a name. A better name is B12 deficiency, because pernicious anemia patients don't have anemia and they're not pernicious. So B12 deficiency is a better name, and pernicious anemia is an old-fashioned name, but that people still use.
Okay. What is the ideal range of active B12?
Well, the range, active B12, I like to see above 75. The range goes up to 150, but I like to see it above 75. And if it's below 50, then I'm really worried that someone has a B12 deficiency.
With regards to the test for active B12 in the UK, the answer is yes, they do test for active B12. I'm not sure,
but the GP doesn't test it, Adelina. You have to order it privately.
Yeah, I mean, I order mine privately at Superdrug, and I think Medicheck does it as well. Can you use an active B12 once supplementing? I'm not sure.
No, because the supplements affect all the B tests. Any B vitamin will make the B test useless.
Yeah, that's super. Okay, we only have 5 minutes left, so I'm going to ask some questions I want to make sure that we really definitely cover. Why do you know about B12, Andrew, and ferritin when other doctors don't? Why is B12 ignored by almost every other doctor and not you?
It's a very difficult question. I don't know. I'm interested in it, but I've done research for the last 10 or 12 years on it. So I'm an anaesthetist. I put you to sleep if you have an anesthetic. I used to use nitrous oxide. I don't anymore, Anne, so don't worry. But, you know, I have been giving iron as part of research studies for 12 years to people having surgery and after surgery to help their recovery. And then our research showed that it's not just people having surgery that need iron, it's just people that need iron. And then people who have low iron also have low B12. So I got interested in it by going to meetings, by listening to patients. And one of my good friends, his daughter died of acute B12 deficiency. So that was a shocking, horrendous, horrific thing that changed my life. And there's many things that happen that change our lives. So we got interested in it, my friend and I. We went to meetings, we learned about it, and we've educated ourselves. So why do other people not educate themselves? I don't know. I go to meetings and talk about it. So I'm trying to educate other people, but it's a slow process. I think it's really important. I think it's really, really important. And I can't stress the importance of it enough. And there are doctors that are interested. You've just got to find them.
And I
As
think
you know, Adelina.
Now, the problem is, I think that they don't get training on this in medical school. I think that's the short answer.
Nutrition is not really covered in medical school, nor are micronutrients, nor are vitamins. So this is because people who teach in medical school are generally the older generation who never learned it themselves.
Yeah,
so we've got to teach the teachers to teach the students to learn it. So this takes years. We need new teachers who know new things.
So another question was, can B12 deficiency contribute to severe food intolerance issues?
No, it's the other way around. Severe food intolerance issues cause B12 deficiency. So it's chicken and egg again. It's the same question that was asked before. The problem starts in the stomach, food intolerances, low or high acid, autoimmune disease. Then over a period of time, you don't absorb B12, you don't produce intrinsic fat, your gut is unhealthy, and then your B12 level goes down. So you need to treat the B12, and then you need to heal your stomach. So you need to avoid the foods that cause the intolerance and let your stomach heal. And nutritionists can help with the food intolerances and the nutritional disorder. But this is about healing the stomach and treating the low B12, low iron, low vitamin D, and low folic acid. So the stomach is the cause, and the low B12 is the effect. And the symptoms come from the low B12.
And is there a connection with Lyme disease, between ferritin, B12? Will injections help?
That's a very tricky one. It is if your levels are low. So Lyme disease, like COVID, causes an autoimmune reaction, and the autoantibodies can attack the stomach and lead to gut problems that lead to low B12 and low iron. So if somebody has Lyme disease, they need to get their B12 and iron levels tested. And if they have symptoms typical of it, then they need B12 injections and iron. So is there a connection with Lyme disease? Yes. If the levels are low and if the symptoms are typical, it's worth trying.
And what about no gallbladder? Will you always need B12 injections if you have no gallbladder?
No, but having no gallbladder does affect absorption, especially of fat, and you can get poor absorption following gallbladder, surgery. So not always. It's not like stomach surgery where it's always, but not always. But in some people who've had gallbladder surgery, they have terrible problems eating, and they have terrible nutritional problems as a result. And then they get low B12 and low iron and low folic acid and low vitamin D. Someone put their hand up, Adelina. I didn't see who. Did you see who?
No, I didn't see who either. If you did put your hand up, maybe message us
something in.
Oh, yeah. Okay, last question, because it's 6:30 nearly, and I don't want to keep you longer than I promised. SIBO is a known cause of deficiencies due to absorption issues, including B12, iron, folate. It can also skew serum blood test results to make it look like a patient isn't deficient when they actually are. What are your thoughts on the link between SIBO, B12 deficiency, and why is SIBO ignored as a genuine diagnosis when it can cause severe deficiency?
It comes back to the fact that many doctors don't believe in functional gut medicine. So SIBO is definitely a problem, and it causes low levels because it affects your absorption. So you get bacterial overgrowth. SIBO is bacterial overgrowth in the gut. So therefore, you don't absorb B12, iron, vitamin D, and folic acid. Therefore, you need to give injections or iron infusions. And then you need to heal the gut at the same time. So again, it's the same answer. You treat the deficiencies and you heal the gut. So you need a two-pronged approach. You need the nutritionist to heal the SIBO, and you need to replace the B12, iron, folic acid, and vitamin D. So remember, all this that we've talked about is a disease of the stomach, a problem with the stomach due to SIBO, low acid, high acid, stomach surgery, gallbladder surgery, anything that affects absorption leads to low levels, leads to symptoms. So we need to replace those low levels. And Nina, one question you've quickly asked, extreme deficiency. I had all extensive tests, number low. Why is that? Well, maybe because the tests are not perfect, as I said.
Yeah.
And things in the supplements. And Kim says, how do you supplement iron with a gastric bypass? You can't, except by giving an intravenous infusion, because you won't absorb iron from if you don't have a stomach.
And
if you have had a gastric bypass, you need iron
infusions. Andrew,
I
don't
have
you?
100 patients who've had gastric bypass surgery and have to have iron infusions and B12 injections.
Last question. You, at the moment, as far as I know, you only treat people over the age of 16. Are there any plans to treat younger or young adults or children? And that's my last question.
So we're setting up a pediatric clinic. We've got a pediatric doctor from Great Ormond Street to help us. So in June or July, we'll be treating young adults, so 12 years plus, really, because this is not just a problem in people of my age, 40s and 50s. I'm not going to be any less discreet than that. It's a problem of older people, and it's a problem of young people. And young people are born with problems with B12 absorption and iron absorption, or develop them as a result of infections or stomach problems or autoimmune disease. So they inherit them or they develop them, and it can cause terrible problems in young people: depression, can't go to school, exhaustion. Young people get terrible neurological problems, even can cause them to think about suicide because they're so depressed. So watch out for young people who have deficiencies, and whoever is worried about it, get tested, but the tests are imperfect. So it's a tricky thing. None of this is easy. Why don't all doctors understand it? Because none of this is easy. As we know, Adelina, with you, it wasn't easy, was it? But we got there in the end.
Yeah. Andrew, thank you so much for your time. I know we got all these questions. I can actually answer some of the questions that Emma's asking, so I don't want to keep you much longer. Thank you so much, Andrew, for this. I will stay on the call for a few more minutes if people want to finish off with some questions, because I do know some of the answers myself. So, but thank you, Andrew. You've been absolutely amazing.
Lovely, and thank you everyone for taking part and for joining in the conversation. And if you do want to make contact with me and you want to come and see me privately, I'm afraid I do charge because it's not on the NHS, but I'd be happy if you wanted to email me, and Adelina can give you my email address. Good night, everyone.
Thank you, Andrew. Really appreciate it. Yeah, I'm really sorry, folks. I couldn't keep him longer, but obviously he's taking this time out of speaking to his family as well, being with his family. I'm happy. So Emma, just to answer your question, yes, you can do the test, because for an under 18-year-old, because you can order it online for them, and they send you a kit at home, and then with a kit at home you can do the test. Now, I don't have children, so I haven't looked into the rules, but literally hang on, I'm gonna stop the recording for this piece because Andrew is no longer involved.